So, image for mandibular fracture, panoramic. Image for condyle fracture, reverse towns. Images for mid-facial fracture, waters, because you will include the sinus. Best view to see zygomatic process, submental vertex. Hit on the right side of the jaw, what gets broken? The left condyle. Fracture in body and mandible. Other fractures occur. Fracture in body and mandible. Other fractures occur. The opposite condyle will fracture, and the condyle breaks for the most, then the angle of the mandible, and the least, and then the coronoid, and the least being the ramus of the mandible. Fracture to compromised patient respiration. Fracture through the body of the mandible. Numbness on the left upper lip, cheek, and the left side of the nose. Infraorbital rim. Now, infraorbital rim, let's see. Infraorbital rim. Infraorbital rim. So the infraorbital will be the nerve that is mostly injured in a Lefort 2 fracture. A patient experienced numbness of the left upper lip, cheek, and the left side of the nose following a fracture of his midface. The symptoms follow a fracture through the infraorbital rim. Infraorbital rim. So maxillary tumors display similar clinical symptoms, but may cause paresthesia of the infraorbital rim. Remember that paresthesia of the infraorbital rim, this will mean that there will be a there will be numbness of the left upper cheek of the upper cheek, the lip, the left side of the nose, the side of the nose. And this will also be seen in maxillary tumors, not only in fractures. So maxillary tumors that display similar clinical symptoms but may cause paresthesia of the infraorbital nerve. So left 2, left 2 gagging of posterior teeth and anterior open bite. Infraorbital is the most common injured nerve in left 2. In what fracture are you going to see subconjunctival hemorrhage? Subconjunctival hemorrhage seen in what fracture? In the zygomatical maxillary complex. Zygomatical maxillary complex. In which fracture you're gonna see periorbital ecchymosis, subconjunctival hemorrhage, left sign, left 2 sign. So a fracture of the zygomatic arch you will have periorbital edema, cellulosis, ecchymosis, okay, so left 3 brings the midface forward, left 3, left 2 periorbital ecchymosis, subconjunctival hemorrhage. Treatment for left 1, bring lower midface forward. Guerin's sign is a feature of left 1.
Guerin's sign a feature of.
Guerin's sign. Guerin's sign. And what is Guerin's sign? It's Guerin's sign is ecchymosis in the region of the greater palatine nerves. Guerin's sign is ecchymosis of the palate, bilateral greater palatine foramen, and occlusion may be disturbed, difficult mastication, pain while speaking and moving the jaw. This is a left 1. So the Lefort 1 fracture, maxillary sinus, frontal sinus, mastoid air cells. Lefort 1 maxillary sinus, frontal sinus, mastoid air cells. Lower lip, none in what type of fracture? A fracture that is in the ramus of the mandible. No, body or angle. Paresthesia is going to be most common in what type of mandibular fracture? Angle of the fracture. Splinting closed bone fracture for how long? 6 weeks. Consequence of trauma to jaw. In kids, it slows the growth. The consequence of trauma slows the growth. It can slow the growth. Child with mandibular trauma, midline asymmetry, ipsilateral. Child with mandibular trauma, ipsilateral, midline asymmetry. Condylar fracture and mandible grows. What happens? Asymmetry. Asymmetric growth with damaged side lagging. What is a sign of mandibular fracture? Occlusal discrepancy. What don't you do for dry socket, curate, and antibiotics? Treatment for dry socket, light irrigation, and medicated dressing. What is fibrinolysis of the clot? Dry socket. The clot diminished and fell out. When patients notice post-extraction dry socket in 3 days, 3 days. Healing after periosurgery, it's a repair healing, repair. Indication for periosurgery dressing, protect the wound. A dressing protects the wound. It doesn't make you heal faster, it will protect the wound. Bony defect between two premolars with no mesial, facial, or lingual wall is a hemiseptum. No mesial, facial, or lingual wall. Bone defect between two premolars, hemiseptum. What does the elevator do in oral surgery? It works as a lever. Hemisection with one wall remaining, it's a hemiseptum. Hemisection of maxillary molar with best prognosis. When the furcation is more coronal on the tooth. When the furcation is more coronal on the tooth, you'll have a hemisection of maxillary mandibular with best prognosis. Root amputation only for maxillary molars. Mandibular molars, hemisection only for mandibular molars. Okay, yeah, so you can do hemisection for mandibular molars and root amputation for maxillary molars. Through and through furcation, what treatment won't work? Guided tissue regeneration. Through and through furcation, what treatment won't work? Guided tissue regeneration. You have a through and through furcation, what treatment won't work? Guided tissue regeneration. Hemisection only for mandibular molars. Root amputation only for maxillary molars. best treatment for type 3 bifurcation, hemisection. A class 3 communication is a through and through. Remember that through and through you will not be achieving anything and doing a guided tissue regeneration. A through and through, the probe penetrates completely from one side to the other, and this is characteristic of severe bone destruction in the bifurcation area. It is clearly shown in the radiographs as a radiolucent area in between the roots, especially in the lower molars. In a class 2, the level of bone loss allows the insertion of periodontal probe into the bifurcation area between the roots. It's not a through and through. In a class 4, the gingival tissues recede apically so that the bifurcation is visible. Okay. In a hemisection, the mandibular molar, it can be done in the mandibular molar when you have a grade 3 bifurcation. They need widely separated roots. Soft tissue position below level of pulp chamber. So class 3 bifurcation has the least success in guided tissue regeneration. A 3-wall defect has the best prognosis for guided tissue regeneration. So this is tricky. 3-wall defect, best prognosis. Why? Because it has 3 walls, and the 3 walls will be giving blood supply. But the least successful is a class 3 bifurcation, because in a class 3 bifurcation you already have a through and through penetration of the explorer or a probe. The purpose of the GTR, the guided tissue regeneration, is to prevent the migration of connective tissue cells, and this is done by holding the space with the bone that is being used, and the tissue is being regenerated through a guide of bone, or not bone, but a membrane. Guided tissue regeneration prevents what from attaching to tooth structure, the epithelium. Let's read a little bit about guided tissue regeneration. So, guided tissue regeneration. So, what is the best prognosis for a guided tissue regeneration? A 3-wall defect, a 2-wall defect, circumferential defect. It's either 2-wall defect or 3-wall defect. I don't know which one is best. I thought it was 3, but I'm seeing different opinions. So, guided tissue regeneration is used in the question says guided tissue regeneration is used in A, class 2 frication. No. B, two wall defect. No. I mean, yes. Sorry. According to Canaan file. Okay, let's see. Guided tissue regeneration. GTR is done when there's coronal attachment. Oh, it's coronal attachment. Well, okay. Let's see, we need to find more about GTR. So, guided tissue regeneration, coronal movement of the periodontal ligament. Uh, okay. There's a question that says if you have a grade 3 frication with endo treatment, it is a mandibular molar. What is the best treatment available? It says here hemisection with 2 crowns. Hemisection with 2 crowns. So in a furcation type 1 and 2, you can do guided tissue regeneration. In a furcation type 3, reposition flap surgery. A guided tissue regeneration is a procedure that blocks the repopulation of the root surface by long junction epithelium and gingival connective tissue to allow cells from the periodontal ligament and bone to repopulate the periodontal defect. The most successful guided tissue regeneration is for class 2 furcations. Most successful guided tissue regeneration is for class 2 furcations or cul-de-sac. Most successful guided tissue regeneration cul-de-sac. The least successful for class 3 furcations. For the least successful guided tissue regeneration is class 3 furcations. The purpose of the guided tissue regeneration is to prevent the long junctional epithelium to migrate of periodontal ligament cells. The migration of the connective tissue cells. Okay, so the purpose of the guided tissue regeneration is to prevent long junctional epithelium migration of periodontal ligament cells. It is a barrier for the coronal movement of cells. Class 1 and 2 gingival recession, it's good prognosis. 3 gingival recession, partial coverage. 4 gingival recession, poor prognosis. Guided tissue regeneration. The non-resorbable membrane will need to be removed after 3 to 4 weeks. There will be some recession, the migration of free gingival margin apical to cemento-enamel junction. The periodontal attachment loss. Periodontal attachment loss equals the gingival recession plus the pocket. If recession, we add it, and if hyperplasia, we subtract it. Okay, so to determine the periodontal attachment loss, you will consider the you will consider the gingival recession plus the pocket. Gingival recession plus pocket, this is going to be the periodontal attachment loss. Okay, how do you determine periodontal attachment loss? Gingival recession, because there is no attachment, plus a pocket, also no attachment. So if this is for periodontal attachment loss. So if there is recession already, we add it, and if it's hyperplasia, we subtract it. Okay, so periodontal attachment loss, the gingival recession plus the pocket will be the result. It will result in the periodontal attachment loss. Now, if you, besides periodontal pocket and gingival recession, you have you have recession, then already you have recession, then you add that to the periodontal attachment loss. And if there was a hyperplasia, you subtract that, because a hyperplasia gives you more than what of the gingiva you had. The most common cause of gingival recession is abrasion of tooth injury. So I'm finding out that Andreas and Salt all May 2018 are the best. Best references. Okay, so going back again, best treatment for type 3 furcation, hemisection. The periodontal ligament and Sharpie fibers are also known as connective tissue. The purpose of the barrier to achieve coronal movement of cells. Guided tissue regeneration prevents what from attaching to tooth structure, epithelium. Purpose of the guided tissue regeneration prevent migration of connective tissue. The least successful in guided tissue regeneration is class 3 furcation. The best prognosis for GTR is a 3-wall defect. The guided tissue regeneration is most effective on a class 2 defect. The guided grafts are better for the maxillary. Guided grafts better for maxillary. An 8-year-old without any anterior crossbite, what do you do? Pedicle graft. A recession of a single tooth, what to do? Free gingival graft. Free gingival graft. So free gingival graft. A free gingival graft is used for, well, yeah, first of all, a graft heals by tertiary intention. A free gingival graft is used for localized narrow recession. Graft receives its epithelium from adjacent tissue and its blood supply from connective tissue. The epithelial formation in 1 week and complete maturation in 10 to 16 weeks. The ideal thickness of a free gingival graft is 1 to 1.5 millimeters. The greater palatine bundle can be the donor side. The epithelium for the graft comes from the donor epithelium. So you will take the epithelium from the donor. The type of healing in SRP, I don't know what SRP is. Okay. Okay, I don't know what SRP is, but the type of healing for free gingival graft, connective tissue, and long junctional epithelium. A disadvantage of a connective tissue graft is that it needs two surgical sites. There's a classification called the Miller classification, and the Miller classification is class 1, in which resection that has not extended to the mucogingival junction without bone loss. Class 2, a resection to or beyond the mucogingival junction without bone loss. A class 3 is a resection to or beyond the mucogingival junction with bone loss and papillar recession. And a class 4 is a resection beyond the mucogingival junction, bone loss to the base of recession defect. So a purpose of lateral graft for gingival recession. Best prognosis for bone graft, a narrow three-wall defect. A narrow three-wall defect treatment is bone graft regeneration. Guided tissue regeneration will be used in a wide and deep three-wall defect treatment. Which tooth is contraindicated in grafting? Maxillary canine. A three-wall narrow is the least likely to need a bone graft. What are the osteoinductive grafts? Autograft and allograft. Type of graft to cause bone loss, osteoinductive. Bone growth, type of graft to cause bone growth, osteoinductive.